Well, good morning, everybody. It's a great honor for me to be here to this very, very important meeting and also to share this table with Professor Branch, that is very well known worldwide about all his knowledge about preeclampsia and obstetric problems. The topic that they talked me is the prevention and management of preeclampsia. There are many parts of this topic that they were just said by Professor Ochoa. But anyway, I think that it's important to say, again, that most of the papers that published in the literature to try to make the relation between antiphospholipid syndrome and perinatal outcome and preeclampsia, most of them are retrospective studies. That means that it's necessary to have more prospective studies just to make the relation between antiphospholipid and preterm birth, hypertensive disorder, pregnancies, or other obstetric complications. And because all the perinatal results are relevant in order to define future management in both mother and fetus. Okay. Of course, you know that we were working in the Fernandez Hospital at the University of Buenos Aires for many years in preeclampsia, and we started including all the relation with antiphospholipid syndrome from the latest 89, 88, at the beginning when they started just talking about lupus anticoagulant. Because all the time we try to find some relation about the severe preeclampsia and the fetal impact, that some other factors could be involved. And immediately when they start talking about the antiphospholipid syndrome, we start just looking preeclampsia in relation with antiphospholipid syndrome. This was a first one that was a prospective observational study in between 2009 and 2010. The end of this study, the main point is that this is a prospective study, and to assess the prevalence of APS in hypertension disorder in pregnancy and the relationship with the perinatal outcome. And we study the pregnant women that develop hypertension disorder in pregnancy during the present pregnancy. And these ladies were studied at the time of the diagnosis of the disease. We start just to the mother, start looking for the antibodies, lupus anticoagulant, advocate, anticardiolipin antibodies, also anti-beta-2, glycoprotein 1. Also, we follow the baby about all the hemogram and platelet count. And of course, we add ultrasound studies and sometimes for the newborn, compute cerebral tomography in selected cases, of course. What we collect prospectively, 50 ladies. 50 ladies who have preeclampsia, 41 of them, superimposed preeclampsia to previous hypertension, 10 patients. The result of the laboratory was classified the lupus anticoagulants as positive or negative, the anticardiolipins higher than 15 at that time, now it's higher than 20. Anti-beta-2 was positive, higher than EGD, higher than 40. And okay, when we check the results, test negative for the 50 ladies, 27 have negative tests, not any antibody detected in those ladies. And 23 has positive antibody. That means that in generally 46% of the ladies has antibodies. And from that antibodies, we realized at that time that most of the ladies have lupus anticoagulant positive. And the other antibodies was random between the rest of the ladies, seven were positive. But the most important point at that time is to say that lupus anticoagulant was the most important antibody present in these ladies. And when we try to say, okay, in the total population, lac negative or lac positive, okay, lac negative, most of the ladies were negative. And we expect that most of the ladies were positive, because all were very severe cases that were booked at the hospital at the time, or they were detected the problem. Okay, we continue just to try to see this data and to try to arrive to some conclusion that was very difficult to arrive, and to say, okay, we'll just check. Specifically in the ladies with pure preeclampsia, how many approximately of these ladies have lac positive. Only lac positive, okay, was 35% plus and two other who's another test positive. And in the cases of superimposed preeclampsia, only two, the number is very small, of course, but the real problem is that we found that only 2 ladies have antibodies positive from the 10 ladies with severe preeclampsia, superimposing preeclampsia. And we finally say that the test positive in preeclampsia was approximately 50%. Half part of the ladies could find that. You can say, okay, what about the perinatal result? To say, okay, just try, we expected at that time, just to find that the cases where lupus anticoagulants were positive has more cases with intrauterine growth restriction. And look at here, the result according to gestational age at delivery. And you can say that there is not a clear difference. We can make a statistical significance because it's a low number of cases, but there's not real significant difference except for the cases for more than 37 weeks. That funny thing is the mean birth weight is higher in the ladies who have lac positive than in the ladies who have lac negative. That means that we cannot find a real relation with intrauterine growth restriction. And we put all together, all the positive antiphospholipid tests, and when you put all the positive, there are maybe some slight difference in the cases where the tests are positive. But again, we cannot find any difference in that. When you try the right to any relation between hypertension and antiphospholipid syndrome, you can say that the prevalence of lupus anticoagulant in generally in hypertension, disease in pregnancy, was approximately 32%. I saw the figures that Professor Branch showed before, and approximately are the same. And we cannot find, it's uncertain, the relation between lupus anticoagulant or any antibodies for antiphospholipid syndrome in relation with intrauterine growth restriction. And I like also to show this, table, because this is at the beginning when we start working with antiphospholipid syndrome. Say, okay, we receive many ladies with a history of previous problems. To say, okay, we are going just to check all the ladies who have problem and to classify according to the Sydney or Sapporo classification. And if you can say, to say, okay, what is the prevalence? Is in generally the prevalence of lupus anticoagulant is 32%. We thought that maybe in this case we can find exactly the same. And if you can see, it is difficult for me just to show, okay, it's here. You can see this part that is then where is placental insufficiency and restriction. This is more severe cases. You see that really there are more antibodies present in that place. But in all the cases together, the antecedents of the history of thrombosis, of fetal death, or recurrent abortion, and the total lady who have the antibodies circulation, only 45 from 215 ladies that were checking at that time. They were not pregnant at that time. There was a history of the previous problem. At that time, what you conclude for that really clinical plus laboratory, that means syndrome, antiphospholipid syndrome in pregnancy related with obstetric problems was 45 from 215 ladies. That means 21%. This is approximately what we're beginning with this figure when you start just working on that. And of course, then we have another small study, and you say, perfect. If you have ladies who have important problem in previous in pregnancy, and we come back again to our hospital, and you see that antibodies present were 12 ladies who become pregnant 16 times after that, and negative 27 who become pregnant 13 times after that. But this lady have in the history that was a previous pregnancy. The reason because they are coming to our department was they have intrauterine growth restriction, stillbirth, abruptio placenta, HELP syndrome. That means very, very severe cases. And said, okay, we're going just to start randomize this lady and to say, why you put some ladies in aspirin, all of them, because all had a history of preeclampsia or hypertensive disease in pregnancy, but we add the low molecular heparin. And you see that you put low molecular heparin and the lady who have antiphospholipid antibody present, because you say, okay, we can put the best treatment for that. And we can say here, the same lady who had problem before, you see that the very severe ladies, but the difference in the next pregnancy, there were 19 pregnancy for the antiphospholipid negative ladies, was just the ladies that didn't receive low molecular heparin because the antibodies were negative, have 1 abortion and 7 cases have hypertension in pregnancy. Mild problems, but they haven't. And in the other group with positive antibodies, that they receive low molecular heparin plus aspirin, there is not abortion and not hypertension, but you can see that the birth weight was really low and very severe cases again because the time at the birth was 35 weeks. That means they don't arrive at that. And now what is continuous thinking about what has happened here. And now we have then to check our poster that you are presented here with Professor Beatriz Gran. I must say that it's the only department who have an hematology working with close with obstetricians. We made exactly the same and check between 2010 and 2020, and that fulfill all the Sydney criteria. In totally were 27. I asked everybody to go to the poster first because you got all the analysis for that. The total pregnancy were 33 pregnancy, 26 with previous pregnancy complication, and 7 with previous thrombotic and obstetric morbidity. And the results were 30 newborns, 2 twins in the middle, 2 fetal deaths, 24 and 33 weeks, 2 early abortions. There were 4 neonatal deaths in women with previous severe preeclampsia and placental insufficiency, 1 woman with previous thrombotic and obstetric APS and triple positive developed a peripartum venous thrombosis, patient with previous severe preeclampsia, placental insufficiency, and triple positive profile show the poorest response to the treatment. And the conclusion that we can arrive, our results suggest that current first-line therapy for antiphospholipid syndrome in pregnancy prevent obstetric complication in women with a history of recurrent pregnancy loss or fetal deaths, but not in those with previous severe preeclampsia and or placental insufficiency, because the ladies become again with problems, maybe not with the same severe problem, but they become again with the problem. We need just to work more on that. Lupus anticoagulant, the most frequent positive laboratory test, we show that the most important antibody is lupus anticoagulant. The poor obstetric outcome was observed in women with triple positivity, for the test. And the division of this syndrome in two groups, according to the obstetric history, it is important. We put recurrent pregnancy loss and fetal death for one group, and the other group was placental insufficiency and severe preeclampsia. And the triple positive profile may facilitate the choice of early additional therapy in these women. Of course, you need to confirm, and we just share with Professor Branch this necessity to be together and to put all the data together, because all the departments that are working very well and made a very good classification and to have a qualified laboratory to work with that, it is necessary to put the data together to arrive at a good conclusion and to decide the best treatment for the ladies. Of course, the comment is, up to now, we cannot find a clear link between the presence of the antiphospholipid syndrome and the development of preeclampsia or intrauterine growth restriction. And we can say very few words, because my topic here is prevention and management, but Professor Ochoa did very well. This is our paper published in 1986 in American Journal about what is normal blood pressure in normal pregnancies. This is a prospective study in collaboration with the Latin American Perinatal Center that is in Montevideo in Uruguay, and we take 1,595 ladies, all taking the blood pressure during pregnancy, and this is the percentile. And what you say is normal blood pressure during pregnancy is 110 systolic, the percentile, the 50 percentile, and 70 millimeters mercury diastolic, plus less 15 millimeters mercury. That means if you have a good control of the pregnancy, early in pregnancy, just at least to take the blood pressure, you can say which lady would be at risk to develop this problem. You can do it at any place in the world with any economical problems. For the management, we can be this chronic hypertension and gestational hypertension, pure hypertension. The only that need is antihypertensive drug just to protect the mother. No, there is not any hypertensive drug in the world who can protect the fetus or ameliorate the situation of the fetus. But the preeclampsia have two syndromes, the maternal and fetal syndrome. And you need to manage the both syndrome, because sometimes they are not working together. There would be maternal big problem with a fetal with not important impact, or vice versa. And that means that you need just to continue and to check in that and to decide that the interruption of pregnancy as not more than 37 weeks, because they are very severe cases. And of course, just to put a touch, because this is going just to talk about pravastatin and statins in the other presentation, there is another big problem that is acute atherosis, that is historic in obstetrics, but now everybody paid attention for that and know that it's an acute problem. And when you try just to do something for prevention or for treatment, what is the purpose? The purpose is to prevent acute maternal complication, to minimize the fetal risk, to continue the pregnancy at close to term, or to try to prevent the morbidity for the future in this lady. Of course, it's aspirin. Everybody know. I was part of the class study. I remember very well how we were working for the class study, and then to analyze the data. Again, many, many years after that, they realized that aspirin is necessary. But what you need to think is that aspirin is just to touch one part of the problem. It's just to touch the platelet activation, the discomfort between prostacyclin and thromboxane. It's not cure the preeclampsia. And that is a very big mistake, that say, okay, I give you aspirin, I solve the problem. Never. We can solve the problem if you just see a big elephant and just only give something just to try to solve what happened in one part of this elephant, okay? That is the reason because we continuous in the world. And there is not any paper in the world who can say that heparin is useful. And of course, that happened because not all the ladies have antiphospholipid antibodies. And pravastatin, the statins that now are in pregnancy, is accepted for the FDA. But what it is that? Because they are working in endothelium, because they have some action in the angiogenic of anti-angiogenic score, and also they restore this balance between the angiogenic balance and improve, especially the experimental studies, especially in ladies. The studies start right now, and also increase the nitric oxide that is endothelium protector. And what can I say? Just to finish with something that also Professor Ochoa showed, that you need just to show at the beginning of pregnancy, just to start, just looking the lady, make a very good nose, very good history. That is the first stage. And this is the first stage you can say this is a low risk and this is high risk. After that, you have this window between 11 to 14 weeks. That means at 12 weeks, we can make the PI. You can start taking the blood pressure again. And this is a grand advantage for my Frankie prosnicolitis to push the obstetricians to take the blood pressure. And the other point is then you have around 20 weeks to check again for these factors, because sometimes they change at that time and the placentation finish. The other, between 20 to 24, is the metabolic detection of the problem during pregnancy. And then you need to follow pregnancy. To follow pregnancy with laboratory tests for the clinical control. Maybe you don't know exactly when you are going to use this score, but you need just to find in this part when we need to ask for the score. That is important, but you need just to find the moment. And important is to say this is a high risk or moderate or mild risk, because this is just to continue and to say, okay, we continue until 37 weeks, or we finish the pregnancy. And those is the most important. To manage preeclampsia is to be with the lady, to detect it, and not to lose this window. Then we can just check the lady by the laboratory to make different tests, to make ultrasound, and you just make the different population between low risk and high risk. I think this is one of the most important things. What you see, continuous thinking, continuous working, continuous making research, and try to find maybe in the future some pill, I don't know, some pill to finish and with the problem. I think really that for the last many years I was working in preeclampsia for more than 30 years, and still we continue just thinking about preeclampsia. And that's just to dedicate all of this effort at my team, at the Fernandez Hospital, at the University of Buenos Aires, Dr. Beatriz Gran, the hematology, the obstetricians, the neonatologists, and the cardiologists who are working all together, very strong team, just to arrive for the best result. Thank you very much for your attention.